Firstly, it's a great pleasure to be with you, especially in Dublin. Thank you for that excessively generous introduction, Ian. It's been my pleasure to be associated with you for several years now in working on the guidelines and discussing how we might progress our field. A number of other friends here this evening, so special pleasure to be in Dublin. Now, the lipid field is a very special one. You might not think so, but let me tell you that it is. It's the field that has benefited from the most Nobel Prizes of any topic in medicine or science. Any. And I'll explain why. But my task tonight is to explain why it's important to treat elevated levels of atherogenic cholesterol, why it's important to diagnose your patients, and why it's important to follow those patients up with an appropriate therapeutic approach. Now, what I will say to you is based on fact. It is based on evidence. And the European Society of Cardiology is an exceedingly formative school in the sense that the criteria that we use when we develop guideline recommendations for clinical application are exceedingly rigorous. And therefore the science that's applied ultimately to interpret the medicine is critical for the development of viable, valid guidelines for clinical application. Now, it also happens that despite the Nobel Prizes in this field, this is the field that is the most misinformed, the most misleading, and the one which has been unduly criticised, unduly misinterpreted by the media and the press. Considerable education is needed around the world, and that's why many of us are investing in efforts to forward education to understand the basics of cardiovascular disease. Now, that's what I'm going to try to do tonight. Please interrupt me. We are on limited time, but please interrupt me if there's a particularly important point that I don't explain sufficiently. Now, hopefully, if you could bring out your telescopes or binoculars on that last table, because you're not going to see a thing, I'm very sorry, I apologise, but we'll go through the slides as a visual backup. And if I understand correctly, they will be available on the Amgen educational site. Is that correct? It is. So, are lipids essential to life? Well, the question very simply is yes, they are. So this is the first family or class of lipids that's absolutely essential to life, triglycerides. Why are triglycerides essential to life? Because each molecule of triglyceride, I don't have a pointer, contains 3 molecules of fatty acids. And fatty acids are the absolute essential substrate to produce ATP, energy, in mitochondria. So the vital substrate for muscle is fatty acid derived from triglyceride, which is primarily in turn derived from the diet. Now you might say, well, no, that's not right. Many organs need glucose as their primary substrate for energy. Well, they don't. What is the main substrate for energy in the heart, for heart muscle? Do you know? Well, it's not glucose, it's fatty acid. So in other words, there are a number of features of these molecules, one of which is that our bodies are actually heat insulated because we have stores of triglyceride subcutaneously. Most people don't realize that. Tonight, I'm not going to be focusing on triglyceride. I simply say that most of the circulating triglyceride is derived from fat in the diet, transported from the intestine in particles we call chylomicrons that contain more than 90% triglyceride. They are broken down mainly in muscle and adipose tissue by lipases. The free fatty acid is taken up and stored. There are remnants of chylomicrons which are ultimately taken up by the liver to be eliminated from the circulation. So let's just say, in this instance, triglycerides, a critical substrate for life. Cholesterol is equally absorbed in the intestine. There's a great deal of discussion about the importance of the amount of cholesterol we absorb from our diet. I'm not going to deal with that. If you'd like to discuss it, we can. Cholesterol, in terms of its molecular architecture, is a beautifully elegant molecule, and it was designed that way. What is special about cholesterol? Well, it's special because it is critical for the structure of cell membranes, it's critical for the production of steroid hormones, it's critical for the production of vitamin D, and it's also a critical precursor of bile acids. Now, what's special about cholesterol is it has a very small, slightly, what we say, non-lipophilic group on it. It has a very, very small charge because it has a hydroxyl group in addition to all of these aromatic rings. And that means that cholesterol can diffuse in very low concentrations out of cells into acceptor particles like HDL. So the properties, the physicochemical properties of cholesterol are exceedingly important for its metabolism. Let's not forget that. Now, cholesterol is tremendously misunderstood, misinformed by the media. There are, at the moment, 12 Nobel Prizes which have been attributed simply to the study of cholesterol. 12. What does that mean? It means it's a critical molecule for life, and its production and metabolism are complex. Now, as I indicated to you, cholesterol is essentially insoluble in water, in aqueous systems. Therefore, nature, going all the way back to the insects, developed particles called lipoproteins. Lipoproteins are mixtures of specialized proteins, apoproteins, bound to different lipids. Some of them are charged, some of them are neutral. Charged lipids, phospholipids, neutral lipids, triglycerides, cholesterol esters. And the packaging of those particles allows their shuttling between sites of absorption, storage, transformation, and so forth. Now, there are two essential families of lipoproteins. The family we're going to be talking about tonight is the atherogenic family, the family that drives cardiovascular disease, the family that drives the formation of plaques in the arterial wall. They all contain one protein, ApoB, very low density lipoproteins, the remnants of very low density lipoproteins, LDL, and lipoprotein little a favourite of Vincent, wherever you are, Vincent, there he is. We're not going to be talking about HDL. We believe them to be non-atherogenic, but they may be moderately atherogenic under certain circumstances. Closed discussion. We don't have time. This happens to be the LDL particles of John Chapman, seen with my own eyes under an electron microscope. This is called a selfie at the molecular level. Now, mammals, many non-mammalian vertebrates possess a very complex biological system to maintain something we call cholesterol homeostasis. What does that mean? It means to maintain steady levels of cholesterol inside cells, inside all cells of the body. Why? Because if cholesterol accumulates as free cholesterol in any cell, it will form a crystal and it will kill ultimately that cell. So rapidly, you need to understand that an excess level of cholesterol in the form of free cholesterol in any cell, if it attains a certain concentration, will kill the cell. So cholesterol is vital to life, but it equally, at high concentrations, is highly toxic. cytotoxic. So there's a system of cholesterol homeostasis which allows cholesterol to be transported from the intestine to the liver. The liver is the main site for cholesterol metabolism, turnover, distribution through VLDL and LDL to peripheral tissues, synthesis of steroid hormones and so forth, and return through the pathway of high-density lipoproteins. Now, how does cholesterol kill? Well, quite simply, it kills because it is a principal driver of the formation of atherosclerotic plaques. You can't see this, which is a pity, but this is a beautiful atherosclerotic plaque in a coronary artery as studied by Professor Falk in Denmark. And this plaque has a large, what we call core, and if you look at that core, you will see there are minute cylindrical structures that characterize it. What are those minute cylindrical structures? They are crystals of pure cholesterol. And we know that those crystals are derived from LDL, but even more, over the last 2 years, we now understand that those crystals can drive the destabilization of the plaque and plaque rupture because they can disrupt what we call the fibrous cap that retains the plaque in the wall. There is a great deal of inflammation at the shoulders of the plaque, and a lipid-rich plaque like this one will rupture if there is a sufficient degree of mechanical stress or spasm or perhaps other factors which will influence the stability of the plaque. One of them is the form and the content of calcium. It's a very topical question at this time, which is why there's so much interest in the calcium score for evaluation of atherosclerotic burden. Sorry, no more time to discuss that. It's tremendously interesting. Now, this is the structure of an artery. Basically, we have the lumen, we have the endothelium, and basically what happens is lipoproteins enter that endothelium into the superficial layers, but they're trapped in what we call the extracellular matrix. Now, why are lipoproteins trapped? Well, it's specifically the lipoproteins which are potentially atherogenic, which contain ApoB, like LDL, and they bind very specifically to what we call proteoglycans and glycosaminoglycans that are an integral part of the basement membrane and the extracellular matrix of the superficial layers of the artery. Now, atherosclerotic plaques don't form anywhere. They don't usually form in the mammary artery, for example. Why? Because it's linear. They form in places where there is turbulence in the blood flow. Great example. Tell me a classical site in the vascular tree of turbulence in blood flow. Abdominal aorta, multiple branch points, carotid, internal branch points, coronary arteries. Why in the coronary arteries? Branch points, but what else in the coronary arteries? None of the coronary arteries are linear. Every coronary artery has a non-linear trajectory. That creates turbulence in blood flow, which in turn induces endothelial activation, increased permeability. Lipoproteins therefore enter the endothelium in a more facilitated way, and if the patient has hypertension, hypertension drives the lipoproteins into the arterial wall. That's the importance of having multiple risk factors that exacerbate cardiovascular risk and exacerbate the process of atherogenesis to form atherosclerotic plaques. We now know that there are essentially 3 processes critical to plaque progression: cholesterol deposition, inflammation, and calcification. These are the particles I'm going to be talking about tonight. Very low density lipoproteins, remnants of very low density lipoproteins, LDL, and lipoprotein little a. Now, in a paper which my friend and colleague Professor Graham is a member, which was driven by the consensus panel of the European Atherosclerosis Society. So this paper will appear in about 2 weeks' time in the European Heart Journal. It's the first paper which documents the causality, and I repeat, the causality of low-density lipoproteins in the pathogenesis of atherosclerotic vascular disease. And that paper is based on genetics and epidemiology primarily. This is a listing of some of the evidence. I won't go into it tonight, but genetic aspects, familial hypercholesterolemia, when we essentially have one risk factor, elevated LDL, and obviously reduction in atherosclerosis and cardiovascular events by effective reduction of LDL. Now, one might say, well, what about the risk factors? What's important and what's not? Well, the most highly cited paper in cardiovascular medicine of the last 25 years is the INTERHEART trial from Salim Yusuf. Across 52 countries, Salim Yusuf identified 9 risk factors, and 9 risk factors only, as being responsible for the vast majority of what we call population attributable risk. And of those 9 risk factors, there was one that accounted for more than half of population attributable risk. What was it? It was an excess of atherogenic cholesterol relative to non-atherogenic, a ratio greater than 3 to 1. In other words, cholesterol carried primarily in LDL versus cholesterol carried in HDL. And that turns out to be a very strong marker, if you will, of atherogenic risk. So let's run around those risk factors rapidly. Smoking, number 2. Diabetes, number 3. Hypertension, 4. Abdominal obesity, 5. Psychosocial stress, every day when you drive through Paris like we do. So that's number 6. Number 7, insufficient vegetable and fruit consumption. Number 8, insufficient exercise. Number 9, excessive alcohol consumption. So 9 risk factors clearly identified in those 9 countries, cross-sectional study for the risk factors for the first myocardial infarction. Now, what is critical to you as clinicians is not necessarily one risk factor, it's the integral approach to the risk factors in any given patient, because that determines their global risk. Now, this is an example of the interaction of 3 key risk factors: hypertension, dyslipidemia, and glucose intolerance. What you see is hypertension alone, 1.5 increase in risk, dyslipidemia alone, 2.3, glucose intolerance, 1.3. But if you're an individual with those 3 risk factors, you have a multiplication of almost 10-fold in your global cardiovascular risk. What does that mean? It means you must absolutely assess all of the risk factors in a given individual and adopt an integrated therapeutic approach. Now, a question that has been asked hundreds, if not thousands of times, is there a physiological level of LDL cholesterol? The answer is yes. So the gentleman at the end of the room who doubts, there is indeed. There is indeed a physiological level. I'm sorry that you can't see the slide. It does indeed, but there is nonetheless a physiological level, we believe. And here is the physiological level, which no one can see, which is very unfortunate. But the physiological level is the level that we have as newborns for up to about the 3rd year of life. And the level of cholesterol at that point is about 0.75 millimolar. Now, why is that important? Well, because we are in the process, in those 3 years, of forming the critical organs of the body, including the brain. Now, why is the brain important? Well, the brain's quite important for one particular reason, apart from cognitive function. What does the brain consist of? Yeah, and the neurons, what is a major component of all brain cells? Cholesterol. Approximately, what is the content, if you analyze a human brain, of that total chemical composition, how much is cholesterol? It's actually a fifth to a quarter. So cholesterol is a critical component of the brain, along with many other sterols and fats. So why is it that full-term fetuses and newborns can actually create those organs in a very satisfactory manner without having 5, 6, 7-fold more levels of LDL cholesterol in their circulation? How can that be possible? Can you tell me? Can you tell me? Well, the answer is very simple. And the answer was found about 50 years ago by a very distinguished gentleman whose name is John Dietschy, working in Dallas at Southwestern Medical School. And what John Dietschy did was he used radioactive isotopes which he injected in the form of precursors for cholesterol. And he took samples of blood, but he also took biopsies, particularly in animals, of all organs and tissues. What did he find? He found that every single organ and tissue in the body can synthesize its own cholesterol. Not only that, when he studied newborns, when he studied newborn humans as well as animals, the rate of cholesterol synthesis in the brain was more than 5-fold higher than it is in the adult. In other words, the newborn adapts to high demands for cholesterol by upregulating its synthesis. Okay, now, very briefly, we know in genetics over the last 10 years that if we have a genetic composition, a genotype, that favors lower levels of LDL cholesterol throughout life, we know that that will decrease our risk for cardiovascular disease. And these are results that are shown for a gene called PCSK9. We'll come back, and here what you see is subnormal levels of LDL cholesterol, less than about 1 millimolar, which conferred an enormous reduction in cardiovascular risk because the individuals were exposed to that low level of cholesterol for life. It's not the same as taking a statin for 5 years in a statin trial. So under these circumstances, there were 80–90% lower levels of risk due to lifelong levels of subnormal LDL cholesterol. And this comes back to the point I made to you about the newborns being able to compensate by upregulating biosynthesis of cholesterol in any tissue which does not receive sufficient from LDL in the circulation. Now, which factors control circulating levels of LDL? I've told you that elevated levels of LDL favor formation of atherosclerotic plaques. How do we control circulating levels of LDL? Very simply, LDL receptors. The Nobel Prize of 1984 to Brown and Goldstein in Dallas. This is the pathway. I'm not going to run into detail. We pick up LDL at the surface of the liver cell primarily with LDL receptors, and we break it down in the lysosome. And the LDL receptor recycles to the surface. What the liver does, the liver secretes cholesterol and triglyceride in the form of very low density lipoproteins. Any tissue or organ with the right receptors or the right enzymes can pick up either the triglyceridase fatty acid or the cholesterol, depending on the level of LDL receptors exposed. And in plasma, these particles will be progressively transformed to become LDL. So LDL is the end product of the metabolism of VLDL, whose function is to distribute triglyceride primarily, but to some extent cholesterol, to different organs and tissues. Hypercholesterolemia. What are the origins of hypercholesterolemia? There are two, primarily. Overproduction of atherogenic lipoproteins by the liver, primarily genetically determined, but polygenic. And the second is a decrease in breakdown of LDL, mainly due to genetic defects in the LDL receptor gene. There are other explanations too, but they're primarily the two I want to talk about tonight. So how do we regulate the LDL receptor? Because that's what's regulating LDL levels. Well, intracellular levels of cholesterol determine the level of expression of the LDL receptor gene. But by almost accident in Paris in 2001 originally, a family from North Africa was identified with premature and very severe cardiovascular disease. And it turned out that in that family there were 4 generations that could be traced, so it was an exceptional family. It was, of course, a consanguineous family, which of course favoured tracing the pedigree through the generations. Now, my colleagues Catherine Boileau, Marianne Abbey-Fidel did that work in conjunction with many of my clinical colleagues in France. And what they found was a gene which is called PCSK9. Normally, it's part of a family of enzymes that activate other enzymes so that they go from a zymogen to an active form. We don't actually know what the real function of this PCSK9 is, and its action may be limited to embryogenesis. That's the current. We have no role for PCSK9 in the adult, at least to this point in time. Now, the LDL receptor, its expression and levels of LDL are controlled by the level of cholesterol inside the liver cell. When levels are low, there is activation of a nuclear transcription factor, we call it SREB, which in turn binds to the gene of the LDL receptor, increases the expression of the LDL receptor, pulls LDL in, LDL levels drop. Very simple mechanism. The statin, if you use a statin, what does it do? Well, it inhibits cholesterol synthesis. It reduces the level of cholesterol in the liver cell. That activates SREB, which in turn activates the gene for the LDL receptor. More LDL receptors, we decrease LDL. Fine. But there's a problem. There's a problem. And the problem is that statins shoot themselves in the foot. Statins do not give the ultimate benefit in terms of the upregulation of the LDL receptor that normally should occur. Why is that? Well, the reason for that is PCSK9. When we have low levels of cholesterol in the liver cell, this nuclear transcription factor is activated, but not only does it activate the LDL receptor, it activates a suicide chaperone protein, PCSK9. And what does that suicide chaperone protein do? It's secreted from the liver cell, it binds to the LDL receptor on the surface, and it triggers its degradation inside the cell. So the statin increases the LDL receptor, but equally it increases the expression of a suicide protein to kill the LDL receptor. So we don't benefit maximally from the upregulation of the LDL receptor that we should obtain with a statin. So this is simply the pathway. I won't dwell on it, but basically the net result of the effect of PCSK9 upregulation is to decrease the number of receptors on the liver cell because it favours their destruction by the cell. Now, in animal studies, it was found that if you developed an antibody to PCSK9, and if you removed a lot of the PCSK9 in the circulation, that you could increase LDL receptors because you diminished the suicide chaperone role. You increased LDL receptors and you decreased LDL. In other words, the pharmaceutical company said, well, look, this is great. This is a new pharmacological target. We can further reduce LDL by developing this antibody, which they did. Amgen did it. Sanofi Regeneron did it, Pfizer did it, and several other companies are doing it at the moment. So basically, when you inject an antibody directed to PCSK9, it simply binds the free PCSK9 and it protects, it gives you the fuller number of LDL receptors which you do not benefit from simply on statin treatment. In other words, this mechanism allows you to add this monoclonal antibody to a background of statin treatment and get further LDL reduction because the mechanisms are complementary. Is that okay? Now, if you develop an antibody to reduce LDL over and above the level that you can with the statin, in which patients would you be possibly likely or probable to need to use that antibody? Well, the answer is quite simple, because there are pronounced unmet clinical needs in this field. There are individuals with progressive cardiovascular disease, progressive atherosclerosis, in whom we do not manage to lower LDL to levels that we recommended, particularly in very high-risk patients, to levels that we recommended in the ESC/ES guidelines. And very rapidly, very frequently, these are patients with familial hypercholesterolemia. Very frequently, they're patients at very high risk with progressive disease, in other words, who have already had one event and either imaging or a second event indicates that their disease is progressive, and potentially a small group of individuals who, for genetic reasons, do not tolerate statins and express that intolerance primarily by statin-induced muscular symptoms. We call them SAMs. But again, outside topic for today. Now, the antibody developed by Amgen is evolocumab, and Amgen developed a very extensive clinical program to evaluate the efficacy and the safety of that antibody across a wide range of phenotypes of individuals with dyslipidemia and high or very high risk. This is the program. I'm not going to go into that, but one of the trials, which is a critical one, is a trial of cardiovascular outcomes, which is called the Fourier study, and the second trial, which is complementary, is called the Glagoff study, and that was a study of the effect of the monoclonal antibody plus statin versus statin alone on coronary atherosclerosis as evaluated by intravascular ultrasound. Now, just let me walk you through very rapidly. So these are agents that give 50 to 60% reduction in LDL. They're highly efficacious. They maintain low LDL levels over time. Injections can be either 2 weeks or 4 weeks, depending on the dose. Do they also lower other lipoproteins, potentially atherogenic, in addition to LDL? Yes, they do. They lower triglycerides, they lower Lp(a), and they lower what we call non-HDL cholesterol, which is all of the particles other than HDL, of course, and they also have a tendency to raise levels of HDL cholesterol, which we won't discuss this evening. Now, you all know that if you use a statin, the degree of triglyceride reduction that you will obtain for any dose is dependent on the baseline level of triglyceride. The higher the triglyceride, the greater the reduction in triglyceride you will obtain. And you can obtain up to 25% or even 30% in triglyceride when triglycerides, for example, are above 250 milligrams per deciliter or more than 2.5 millimolar. This is an example from Evan-Stein, and it simply shows you that as you increase baseline levels of triglyceride and you use evolocumab on top of a statin, you can actually attain up to, well, more than 20% reduction when your triglyceride levels at baseline on statin are above about 2.5 millimolar. Now, why is that important? Well, it's important because over the last 5 years, the whole scientific and clinical horizon around triglycerides and hypertriglyceridemia has changed dramatically. The reason for that, there's two reasons. First of all, large cohorts have been studied over considerable periods of time, in some cases 10, 15 years. Secondly, we tend to measure triglycerides in the fasting state. If you measure them in a non-fasting state, you have a much greater chance of detecting individuals who may have inadequacies or diminished capacity to break down triglycerides. Diabetics are a very good example. So Borg Nordestgaard in Copenhagen and a number of his colleagues started to compare information on cardiovascular risk from individuals whose triglycerides were measured fasting or non-fasting. Now, when you measure non-fasting, you get a much greater range in triglyceride. You can go up to 4, 5 millimolar. To cut a long story short, by doing that, they were able to show in excellent quality publications that there is a clear, highly significant correlation between elevated levels of triglyceride in the postprandial phase, myocardial infarction and stroke and all-cause mortality. So we are in the middle of a dramatically changing era with respect to triglyceride. We now recognise that triglyceride-rich particles represent a major cardiovascular risk factor, and there is now an EGID across Scandinavia, in Sweden, in Denmark, and I believe Norway. The standard measurements of triglyceride are now performed on non-fasting blood samples. The only problem is obviously glycemia, but you can measure HbA1c. Lp(a), Vincent is here. I won't go into the structure and so forth. If you'd like to know about Lp(a), about 5 years ago, our ES Consensus Panel published a handbook as well as an app. It's on Android and on Apple, and we've been told it's very useful. We're about to update that because of the new risk factor data. Quite simply to say, there is an efficacious reduction up to 30% of Lpa levels with this monoclonal antibody, with evolocumab, with alirocumab, with bocosuzumab, till it was withdrawn. Now the point here is, and be careful, reducing lipoprotein delay by 30%, if your Lpa is not at a level consistent with elevated cardiovascular risk, in my own opinion, has very little interest. It's when you have an Lpa above the 80th percentile, above 50 milligrams per deciliter in our units, that may well be significant in reducing cardiovascular risk. That is yet to be proven, but we do hope there will be new data from the Fourier trial, which I'm about to describe to you. Now, let's just look at plaque. We know from the statin trials, using intravascular ultrasound, that if you reduce LDL levels down to about 1.5 millimolar or slightly higher, 1.8, that in the majority of patients, you can stop atherosclerosis as measured by intravascular ultrasound. The majority of patients, not all. Probably 30% of patients still need, in our interpretation, still need to come down this curve to lower LDL concentrations, hopefully to prevent progression of plaque. Now, what was done, a study called GLAGOF was performed by Steve Nichols in Australia. So this is placebo statin, standard care, versus evolocumab on a background of statin, using intravascular ultrasound. I'm afraid I don't have time to really go into much more detail. I'd just like to say there are two parameters to be measured here. One is called percent atheroma volume, the other one is total atheroma volume. There was a small degree of regression using what is called the percent atheroma volume endpoint. It's the endpoint that the investigators feel is the most informative. I don't have time to go into that. I would say, because atherosclerosis never involves one plaque, atherosclerosis is a diffuse disease. And very frequently, it's not just one vascular bed, but at least two that are affected. So the point I'm making here is that when you look at total atheroma volume, you're looking, in this instance, across the length of a target coronary artery with disease. And in this instance, the degree of regression was of the order of 5%. Now, don't interpret regression, or don't overinterpret regression. What does that really mean? It means that the plaque is being remodeled. Lipid is being taken out of that plaque, or is not entering the plaque as efficiently as it did before, and we change plaque composition. There's ample data to show reduced inflammation, to show increased fibrous content, to show increased thickness of the fibrous cap on statin treatment. The other point is that there was an important subgroup in this Glagoff trial with LDL levels slightly above 0.5 millimolar, evolocumab plus statin. And those individuals, so these are, let's just repeat this, these are individuals, 0.5 millimole of LDL cholesterol on treatment. 80% of those individuals with that LDL below current target regressed their atherosclerosis. So a very clear signal that going beyond current targets for LDL is consistent with regression in a major proportion of patients with incident disease. Very favourable safety. I'm afraid I don't have time to deal again with this, but no neutralising antibodies were detected. Very important point. This led to the withdrawal of bocosuzumab, and I think that either Patrick or Gavin will speak on that. Okay, now, one of the points about regression, how does that translate into cardiovascular events? Well, there is one study in the literature which translates that, and I'll simply read it to you. Regression of coronary atherosclerosis was associated with a significant decrease in 8-year all-cause and cardiac mortality, whereas progression was associated with a significant increase in cardiac mortality. So in other words, we're moving towards a new era when imaging of coronary arteries is going to be highly informative with respect to risk of events. Let's come back now to this very important outcome study that was just reported at ACC. So this is Fourier, 27,000 patients, slightly more, randomized to placebo, statin, or statin plus evolocumab. This was a very high standard trial. Very, very few patients discontinued, 5% or less. Very, very few. 5 patients were lost to follow-up on evolocumab plus statin. That says a great deal for the tolerability of that combination. Now, let's look at the baseline characteristics. Well, primarily males, average age 63, 80% myocardial infarction within the last 3 years, stroke 20% almost, and the largest cohort of individuals with peripheral arterial disease, more than 10%. In other words, about 2,500, 3,000 individuals with peripheral disease, never studied before in a lipid-lowering trial. Other cardiovascular risk factors, 4 out of 5 with hypertension, 1 in 3 with diabetes, 1 in 3 smoked. High risk, very high risk. What was the profile, the lipid profile? Well, 70% high intensity statin, 30 on moderate. So they'd been exposed to a statin. We can expect there's been some degree of plaque stabilization due to statin treatment. We don't know for how long. We don't know the average exposure to statin in this trial of those patients. It would be important to know. Baseline LDL 92, in other words, 2.2, 2.3. HDL cholesterol, slightly more than 1, and triglycerides, about 1.5. So that was the baseline characteristics. What was seen for the combination of evolocumab plus statin, essentially a 60% or 59% reduction in LDL, very nicely maintained, stable over the period of the study, at least stable according to the time points when it was measured. And the median LDL was 30 milligrams per deciliter, so that's 0.75 millimolar. Never before have so many individuals in a trial been exposed to such low levels of LDL cholesterol. Primary endpoint. The primary endpoint was a composite: cardiovascular death, MI, stroke, hospitalization for unstable angina, revascularization, and what you see. So the median exposure in this trial was 2.2 years. but there were individuals less and some individuals more. And basically these Kaplan-Meier curves are representative of individuals out here at 3 years of exposure. And there were around about 6,000 patients exposed close to 3 years in the evolocumab statin versus placebo. And what you see is about a 20% benefit, 15% benefit with the hazard ratio of 0.85. And if you look at the hardest endpoint, which is secondary, CV death, MI, or ischemic stroke, you see a 20% benefit, but actually the correct numbers on this, I ought to give you the numbers because they're important, slightly more than that. So there was actually of the order of 27% reduction in myocardial infarction and 21% reduction in stroke within that data. Now, mortality. What happened to cardiovascular mortality? The median exposure was 2.2 years. If we look at the statin trials, then for the most part there is a separation of the lines for mortality at around about 2.53 years. This was the case in 4S. It was also a little bit later in lipid, a less potent statin. We look at other statin trials. In some of them, or ezetimibe, improve it, no clear cardiovascular, no clear benefit for cardiovascular mortality. In the more potent, improve it, high dose statin, TNT, we do see a tendency here for benefit on cardiovascular mortality. Cardiovascular death, yeah. Now, what about the levels of LDL attained on treatment in the Fourier trial with the evolocumab statin combination? Well, the levels of LDL attained on treatment were quartiled, and here you see the 4 quartiles, and the lowest is of course around here at 20 milligrams per deciliter, but you clearly see the trend, the greater degree of benefit as you, as you move to lower achieved LDL, the more you reduce the incidence of events. So lower LDL is highly efficacious in reducing events, and the question ultimately will be cardiovascular death, because the trial is being continued. There's going to be follow-up of a large number of patients for further data on mortality, so we'll have to wait for that. Now, safety. Safety was excellent, but there are 3 points to make. The first point is, many of you will be aware of the statin-associated muscle symptoms, usually symmetric, typically pharmacogenomically based, as originally found in the SEARCH trial by Rory Collins and his colleagues. Here you see no significant signal. There's been no significant signal for any muscle-related symptoms in any of the trials with these monoclonal antibodies. Secondly, diabetes. You'll be well aware that there is a signal for dysglycemia, and the latest paper I saw yesterday, which is an Australian observational paper, indicates that there is a 50% conversion to diabetes on moderate to high intensity statin in postmenopausal females of 70 years and over. So in other words, there is a very, very high risk of switching to diabetes in postmenopausal females, on moderate or high intensity statin. It's taken a long time for us to obtain those data. Statins have been available now for almost 30 years, but we need huge databases to detect those sorts of risks. We also know there's a 42% conversion in the METSIM trial in Finland in individuals with the metabolic syndrome risk factor cluster, again for switching to diabetes. The final point, neurocognitive. So the FDA told us that there was some concern for neurocognitive impairment in individuals treated with statin, basically because a couple of the members of the panel forgot their car keys and they were taking statins. It's actually serious. There's been no systematic study with statins using rigorous clinical indices or tests, diagnostic tests, to really show in a prospective study whether or not statins are associated over time with cognitive impairment. What we can tell you is there is no signal for neurocognitive impairment in any of the studies so far with these monoclonal antibodies. The Ebbinghaus study was a sub-study of almost 2,000 patients in Fourier. It was presented 10 days ago in Washington at ACC. There is no signal using CANTAB criteria, exceedingly rigorous criteria, particularly for short-term memory, but other indices too. So at the moment, we have no signal. This is only 4 or 5 years maximum exposure, of course. In this instance, it was relatively short. We don't know if individuals, for example, who are on the track of cognitive impairment, they've already presented with a stroke. We don't know if there might be any exacerbation due to impairment, for example, of the blood-brain barrier. All of those questions, they're in the future. So, and very importantly, no neutralizing antibodies. So just a comparison with the cholesterol treatment trialists, very comparable data on reduction of cardiovascular endpoints after 2 years. And I just leave you with this box. This is the recommendation we made in our European Heart Journal paper from the task force of the ESC and EES last December. We targeted here essentially 3 major groups in whom we believe that these inhibitors could bring additional clinical benefit to a statin. The first group are those with progressive cardiovascular disease or diabetes mellitus with target organ damage, including FH patients with documented disease. The second group obviously is heterozygous FH, and the third group is homozygous FH, and a very small group, statin intolerance. Now, you may have forgotten everything I've said tonight. There might be a reason for that. There is one major risk factor for cognitive impairment and for degradation of cognitive performance over time. Do you know what that risk factor is? None of those. So this is a true story. So this is the Whitehall 2 study, Sir Michael Marmot in London. He recruited 5,000 senior civil servants and he followed them for 5 years, males and females. And what he did was he performed a number of cognitive tests at baseline and at periods through the study. One parameter, and only one, predicted cognitive impairment, significant cognitive impairment. It was subnormal levels of HDL cholesterol at baseline and further fall in HDL cholesterol over the period of the study. So let's not throw HDL out just yet. Everything I've said and more you can find on PCSK9 Forum. We had real-time reporting at ACC. It's totally non-profit and we hope it's educational. So there we are. It's been a pleasure. I apologise. I've taken far too much time and it's a pleasure to be in Dublin. Thank you.